And actually, going back to the other case, there was a similar case that Bill Lombardi and his colleagues reported where it was a left atrial hematoma and compressing, causing relative mitral stenosis. And he had his endoscopist stick a catheter, stick a needle from the esophagus into the left atrium to drain the hematoma to treat shock. And that's been published as well. So there are 2 published reports, one on my end with the CT on the right side, and then Bill's case with the left atrial on the left side.
Well, thank you. This is the first case presentation session where people are standing in the room and there's a lot of interest. And you feel kind of glad that is the case that you see is not yours. This is not necessarily a complication. It's certainly a complex case that happened many years ago. Tim, you will remember this. And it's a case that, you know, the kind of case that you never want to see when your wife is pregnant. I was a fellow at the time, and it kind of came close to home. This is a very young woman, 34. She presented a week postpartum with an out-of-hospital cardiac arrest. She really had no significant medical history at that time, presented with BFib, and she regained ROSC after about 30 minutes of CPR. She was shocked multiple times before arriving to the cath lab and arrived intubated on an EpiDrip. There's a lot of controversy about taking people to the cath lab after cardiac arrest when there is not a STEMI. In this case, it's not the heart. You see there is a very extensive current of injury in the anterior leads and the lateral leads as well. The coronary angiogram, I think you'll all be thinking about coronary dissection, and that's what she had. She had an extensive dissection that extended from the left main into the LAD, involving the diagonals as well, with very limited flow. The circumflex artery as well as the right coronary artery were okay, and wiring was not difficult in this case. Sometimes it can be very challenging, but it wasn't. And you can see 2 long balloons going up, and she ended up receiving a total of 3 stents. And this is the final result from distal to proximal and into the left main. You can see a balloon pump in the background. She went to the ICU. This is the right coronary artery. It looks so fine. And she did sort of okay. This is the summary of the angiographic findings. Ended up getting 2 very long stents in the LAD, 275 by 38 and a 35 by 20 in the left main that was post-deployed 240. Therapeutic hypothermia for 24 hours, balloon pump. Had a cardiac MRI that showed a significant reduction in LV function, EF of 35%. CPK peak at 11,000. She did have a good functional recovery despite the prolonged CPR. And because her ejection fraction was 35%, she was eligible to participate in a stem cell trial. The trial required mandated angiography before stem cell infusion, and this is where things became a little bit more interesting. As you can see here, she has feeling defect in the stents. You can appreciate that in the mid portion of the LAD, suggestive of subclinical stent thrombosis. Manual aspiration, mechanical thrombectomy, aggressive balloon post-dilatation, and intravascular ultrasound, which I'll let you take a look at this image. It's about 25 seconds. Where you can see there is a significant hematoma that persisted there, leading to a stent malapposition. There can be almost, in some parts of the artery, almost 360, and the stent is just floating there. And the challenge was how to best manage this. Any ideas from the panel? Any suggestions or?
Anyone? Ashish?
I mean, I know what's not right. Dilating this more is not the right answer.
Correct.
That I know. How to manage this correctly, I'm sort of, it's hard. I don't know if this is.
And this is the reason why it's not the right answer, because this is almost like,
I
trying to
guarantee
squeeze
if you dilate this again, this is what's gonna happen.
toothpaste. So you're essentially
You do not want to
propagating
dilate it
that.
The MRI didn't show viability of the intraapical wall, right?
Correct.
So-
The apical LED segment was already dead. Yes, that's correct.
And I guess that argues the well enough alone. And what are we resupplying at this point?
Correct.
Redilating it is going to lead to this.
So your point is well taken. We did post-dilate, try to make that artery look better, and you can see that the apical LED we lost flow by propagating the hematoma, and you have to dilate the distal segment, ended up getting another small stent there. This is how we look at the end. Angiographically look okay, but you always wonder how it's going to be in the long term. This is a summary of the findings of the follow-up angiogram, extensive coronary dissection with intramural hematoma. We reballooned the entire LAD, put another stent distally, and switched her to Procedural. She was on clopidogrel prior to this. She ended up going home after almost 3 weeks in hospital, and she had a very good hospital course. Her ejection fraction improved to about 45%. She ended up not needing an AICD. And the angiographic follow-up was done with non-invasive CTA, and you can see the stent is still patent, and it looks like the hematoma has resolved, as is normally the case with time. She's on heart failure therapy. Some take-home points. It's important to recognize the limitations of what we do. I think when you stent these cases, you may not know the true size of the artery, and even if you do, you have to take into account the presence of significant hematoma blood in that space. Surveillance angiography may be necessary to confirm that the stents are well opposed with advanced imaging. What to do about that is less clear. And sometimes participation in clinical trials can be useful to understand what's going on. I do want to just bring to your attention, there is some data. This is recently published in JACC from Mayo. They have this prospective registry that has been going on for now, I think, 7 years. This is uncommon, but it's not super rare. I think all of us have seen one or two of these cases. This disease tends to happen within the first month of pregnancy and usually within the first week in the majority of cases. Because it involves a mother and a newborn, there's a lot of drama associated with it. Relative to a spontaneous dissection that occurs outside of pregnancy, these cases tend to present with a more dramatic presentation. They tend to have a STEMI or cardiac arrest, like in this case, and they tend to affect the left main and the left anterior descending artery in almost 2/3 of the cases. There's a lot of research that needs to be done, but these appear to be related to the hormonal fluctuations that occur during pregnancy and around the time of delivery. These are very challenging cases to manage. Both, I've seen cases that end up going to CABG sometimes, and even the surgeons have a hard time anastomosing a graft to these arteries because there is so much blood in them. The risk of recurrence is not zero. It's about 10% at 5 years with subsequent pregnancies, and it's about the same as it would be for someone that has this disease outside pregnancy. So there's no significant difference in that regard. Thank you very much for your attention, and I'll take questions.
Excellent presentation. A lot of good teaching points. Obviously, when you treating these are difficult, what the right thing to do is, and sometimes medical therapy might be the right thing. Obviously, if you stent the false lumen, you can lose the vessel. One of my colleagues was stenting a Proximal LAD and retrograde dissected back to the left main all the way down to the left cert. I know. So they're really difficult. And, in our vascular medicine folks follow these patients, and truly they think that there's high likelihood of muscular dysplasia of these patients, and they actually screen them. There are great vessels, correct, especially in the CNS, for abnormalities. So something just to keep in mind.
I think your first...
But this is not atherosclerotic cardiovascular disease.
Correct.
It's quantitative dissection. Then most likely to look for is connective tissue disorder, like Ehlers-Danlos or that kind of stuff.
Correct. So the Mayo group presented in that paper, both points are true when you're talking about non-pregnancy related coronary dissection. This appears to be a different entity. So the prevalence of fibromuscular dysplasia was much less in pregnancy. But absolutely right, when you have this presentation outside pregnancy, you have to be thinking about fibromuscular dysplasia.
Just a comment about the hematoma treatment. So obviously this was a little bit different because it was already stented, but if you do have a hematoma in the context of a CTO and you're trying to do something that you need to, at the edge of, say, where you re-entered, and you have a slow flow or a narrowed vessel, the treatment there is a simple cutting balloon or a simple scoring balloon, and that kind of just is able to recreate the lumen without having to put a new stent in. Because as you said, putting in new stents just generally creates toothpasting effect, and putting in new balloons just creates no problems.
What's the rationale behind choosing
More potent platelet inhibition, but there is no data. If that's the point you're trying to make, yeah, that's correct.
Very good. We may go ahead just to
Tim?
keep on time.
Yeah, just a really quick comment about, a lot of the prevailing view on SCAD is that you should treat conservatively. But obviously in a STEMI, this is a whole different situation. And we have a very large series now that's Minneapolis Heart and Cedars with just STEMI in SCAD. And the fact is they can be stented very successfully. And in over 60 people, death at 1 year was only one person. And there was a high percentage of left main spontaneous coronary dissections as well. So if you have decreased flow, ongoing symptoms, cardiogenic shock, you clearly need to fix it. And they can be done very successfully with stenting if you're careful.
Tim, in your series, has there been any how do you manage the left main bifurcation?
Yeah, stenting. And it's because, there's not, surgeries really, there are a very few number of people with surgeries. The ones that you saw, like you saw the original one, which is very extensive. Yeah. The bypass is just not an option. And not doing anything is not an option, right? Because cardiogenic shock, and she would have died. But you can, if you have to be very careful to be in the true lumen. You have to make sure you get the origin. It's essential to get the origin. And I'll tell you, that's a mistake people make. So, but in centers that do a lot of STEMI, it turns out that, SCADA is a part of our STEMI is about 1% of our STEMIs. And this is 2 large centers. So it's not rare, and it's under-recognized, but it's very, very, very treatable with good long-term results if you know what you're doing.
What is the selection of stent that this patient will be? Is there any different people using drug-coated, not drug-coated stent? Because they're not atherosclerotic disease.
I think in a young patient, it was funny, on my way here I was reading an editorial from Antonio Colombo in JACC saying, should we get rid of bare metal stents in the cath lab? Because I do think that with the newer generation stents, even duration of antiplatelet therapy can be shortened significantly. So I think in a 34-year-old patient that's going to get almost a full metal jacket in the LAD, I think most people will favor drug-eluting stents. I don't know if the panel has any comments about that.
I agree.
Because even though there's not atherosclerotic, the restenosis process in the drug-eluting stent is neointimal hyperplasia from the stent that you put in. So neointimal hyperplasia has nothing to do with atherosclerosis. It is just a response to the stent. And so that's going to be 1 no matter what with any drug-eluting stent. So, and that's reduced to 0.1 with drug-eluting stents that's so clearly this benefit. Your TLR rates will be 50% lower.